You are listening to the
World Extreme Medicine.
The World Extreme Medicine
Podcast.
In this session, we're going to be speaking with Marian Dover around the life of a rural generalist in remote Australia. So what I wanted to do is really spotlight the incredible world of a rural generalist in remote Australia. But for many doctors, the decision to work in rural and remote areas isn't just a career choice, it's a calling. So today we're going to talk about what it means to start out as a rural generalist, a role that demands versatility, resilience, and a sense of adventure. So rural generalists are at the heart of Australia's healthcare system in some of its most challenging environments, from managing emergencies in isolated clinics to building meaningful relationships with patients and communities. So in this episode, we're going to explore the journey of beginning a career as a rural generalist, uncovering the highs, the challenges, and indeed the moments that make it all worthwhile. So we're going to hear first-hand experiences, practical advice, and personal stories from a doctor who leapt into remote medicine. So to do this, we have Marian Dover with us. Marian was born into a family that migrated to Australia from the Middle East. Marian experienced the challenges of building a new life in a foreign land. Learning English alongside her parents, she adopted a new culture and found safety and opportunity in Australia. So Marian's dedication led her to the Australian College of Rural and Remote Medicine, where she found a supportive community that reignited her drive. So today, she and her family thrive in East Kimberley, where she embodies the spirit of rural medicine and reflects her journey with pride and gratitude. So the Australian College of Rural and Remote Medicine recently recognised Marian as the 2024 Registrar of the Year, celebrating her exceptional contributions to rural healthcare and indeed her commitment to community wellbeing. Welcome, Marian, to the podcast.
Thank you so much. Thanks for the lovely intro. It's great to be here.
It's great to have you with us, actually. I just wondered if we could start fundamentally with your personal journey, Marian, if that's okay. Just what inspired you to pursue a role in rural as a rural generalist, and indeed, what led you to begin a career in remote Australia?
Yeah, I think growing up in the Middle East, I had parents who were very hardworking, who sought a better life for my siblings and I. And I think over the years they instilled a really strong work ethic and a strong sense of justice. And as soon as I sort of was introduced to the world of rural journalism and rural medicine, I think a lot of the themes really resonated with me. People not having enough access to healthcare and having a shorter life expectancy, the gap in outcomes for Indigenous First Peoples and the rest of Australia. They're all things that I don't think are things that I would accept. I think it's something we all should be working towards, and I became a doctor to help where I'm needed most. So it made sense that I ended up in rural medicine, I think.
No, absolutely, absolutely, and I think, like you said, there's a certain extension of equity of care in these areas where you can start to really level the playground for actually equity of access and indeed equity of healthcare. Could I get you to speak to your medical training? Because I think as a rural generalist, and I'll get you to unpack this, the medical training, there's a certain element of versatility for the unique challenges of practicing in rural and remote settings. Could I get you to speak to that?
Yeah, I think in rural medicine, we have this privilege of being able to mold to the needs of a community. So we come to a community with a diverse skill set. And when I was sort of starting out in medical school, someone asked me, like, what kind of doctor would you want to be if you were in a party, for example, and someone just, had a cardiac arrest? What kind of doctor would you want there? And I was like, yeah, that's a really good point. I'm not sure I'd want to be sort of the partialist who can only sort of, excise certain skin cancers or only looks after, children with a certain glioblastoma, a very, very narrow sort of scope. I wanted to be someone with a really diverse skill set and someone who can adapt to the environment and adapt to whatever the needs are of the community. So yeah, I think the other sort of comment that someone made was a rural generalist is a little bit like a Swiss Army knife of medicine. You carry all these skills that you pick up along the way. So I'm the type of rural generalist that a lot of people feel safe having around because I can do a caesarean section, which is probably the most scary surgery that you can do because of the unpredictability of it. But I can also insert a chest drain, and I can intubate people. And having that diverse skill set just means that the community benefits so much from not having to sort of go for hours without accessing really vital care.
What were some of the biggest challenges, Marian, of your entry into rural and remote medicine? Because you've just mentioned there, and I think it's absolutely true and fascinating. You have to have multiple competencies over multiple skills, and even maintenance of competency is challenging when some of these may be fringe or, high acuity, low occurrence skills. But could you speak to me some of the main challenges that you experienced when you entered into remote medicine?
I think that becoming a rural generalist takes a certain amount of clinical courage. There's a lot of situations where, yes, you're dealing with primary care and you're doing that important preventative medicine that every community so badly needs. But at the same time, there's also times when accessing help is hours away, and it does mean that it relies on your ability to sort of go back to basics and know when somebody experiences this symptom, I really need to make sure that I rule out this life-threatening condition. And very rarely, that it can progress to that, and it sort of gets to that adrenaline where you have to make decisions quite quickly and think on your feet quite quickly, and have a broad set of differentials so that you're ready for whatever happens next. So I think clinical courage is one of those things that like you said at the beginning, it's almost a bit of a calling. The unpredictability is something a lot of people might not necessarily like, and they like having a bit of control over their situation and control of their environment. But in remote settings, that's not always possible, and you need to be quite adaptable and have the clinical courage to use the skills that you've built up over the years.
Marian, could I get you to speak to the differential between primary care and indeed emergency medicine? In my mind, it would be maybe, I don't know, 90-10, that it'd be 90% maybe the primary care, the slips, trips, fits, feints, funny turns, compared to the 10% of, high acuity. Would that be sort of an accurate statement?
Yeah, I think it is. 90-10 is probably a good guess of the proportions that we get. But yeah, as much as, the adrenaline pumping stuff is really satisfying, I think a lot of the battles that we win are in, that primary care setting where you're sitting with a patient one-on-one, you're developing that trust, and you're preventing things from happening. That relationship's really important when you're working with a patient. And, I always say there's absolutely no point to becoming a doctor or doing medicine if you can't communicate with a patient and you can't convince them to do, the treatment that's going to add years to their life.
So could I get you to speak to just some of the semblance of professional isolation that you might feel in a remote location? And indeed, how does that feel, and how do you navigate it in practice?
I actually challenge that thought of saying that we've got professional isolation. I've always told people that as a rural generalist, I actually feel more connected with my community and my team than I ever did in the city. Yeah, I was born in a small place of 22 million people in Cairo in Egypt, and it's so easy to be anonymous in a community like that. You might never speak to your neighbor, never actually get to know the team members that rotate so rapidly in a big environment. Whereas in the country, you're almost like a big fish in a small pond, so you get to know people really well, and I actually feel much more connected in the country. I think it's almost a little bit of a myth that the social and professional isolation is a deterrent from becoming a rural generalist, because I've experienced the opposite.
So listen, I would actually fundamentally agree with that. Living in cosmopolitan and metropolitan areas versus rural areas, like you say, you're far more well known in those areas. And I guess my next question and pivot would be around the impact on personal life, Marian, and how you've navigated personal life. Just according to your answer there, I think, like you said, maybe it's easier to build up a community in a rural setting. Could I get you to speak to that?
Yeah, I think so. So the final year of medical school that I did was in a place called Lithgow in the Blue Mountains in New South Wales, and when I turned up day one, I was heavily pregnant. And even before the baby was born, I was getting offers of people to babysit for us and to look after the kids when I was called in the middle of the night. So I think that the sense of community is really strong in a rural area. And from a personal point of view, some people wonder whether raising a child in a country area is worthwhile because perhaps there's ideas that the academics might not be as strong. But I also challenge that and say, I think my kids are actually learning a lot outside of academics. They're learning about privilege. They're learning about, the different backgrounds that people come from, and they're much more accepting. And I'm hoping that means that they will become, human beings that are kinder, who understand people better.
So you mentioned already, Marian, about this community engagement within your practice and indeed as an extension of who you are. Could I get you to speak to the community engagement as far as public health is concerned? Because there is an element of and an interplay of public health within your role because you are so deeply embedded within the community. Could I get you to speak to that?
Yeah, totally. So in Australia, we do have a very big gap in health outcomes for our Indigenous First Peoples compared to the rest of Australia. And you'll see that in a lot of the research that we've done, the programs that are built from a community, that are initiated by the community, are the ones that are more likely to thrive and more likely to have better outcomes. When you have sort of an outside person who assumes that every rural community is the same and wants to sort of spread a program for every rural community, thinking that we're all the same, you're much less likely to have good outcomes from that. And so it's so important to have community-driven projects that are, from the grassroots. One thing that I've been really passionate about is rural maternity units and the impact that a closure of a rural maternity unit ends up leading to. Australia, unfortunately, has lost 50% of its rural maternity units in the last 20 years. And the ones that have reopened, the success stories of maternity units that have reopened, which is so difficult to do, have actually been community driven. It's been the patients and the consumers who've driven that and reopened maternity units in some of the small places where we knew that women would have to drive kilometres whilst in labour, which is terrifying, and sometimes end up birthing on the side of the road. So yeah, I think from a public health point of view, you really need that community engagement and need the community to trust that the people who are there to help are actually there to help and not with an ulterior motive.
Could I get you to speak to a sense of teamwork, Marian, within your role? I mean, one of the issues, and indeed maybe technology-enabled facets of your role, is the fact you hopefully have this semblance of MDT now, so multidisciplinary team working, where you have reach back. You have, if you have a difficult patient, you can get on a Zoom call or indeed a clinical call with colleagues. Could I get you to speak to that sense of teamwork, which is maybe one digital step away?
Yeah, absolutely. So there's nothing that I do day to day that I do alone. Everything is team-based. And we have to sort of move away from the idea that, we've got GP-led care or midwifery-led units or things like that. It's team-led care. Often you'll see, even in an operating theatre, I give this as an example, the operating theatre that I step into where the team has worked with me for quite a while and they know what my mannerisms are like and they know my facial expressions and things like that, I think it just goes so much more smoothly. Just a couple of weeks ago, we did a really difficult caesarean section, and the anaesthetist knew me and knew what my face looks like when there's a lot of bleeding. And this is probably a really good example because they knew that that over the drapes they were like, Marian, do we need some tranexamic acid? Are you happy with the tone? They could tell that from my mannerisms, because the team knew me so well, that things were quite difficult. This wasn't a straightforward one, and I just think it would be really great to capture that in some of the data, because undeniably we would achieve better outcomes for patients because the team is so cohesive and we work together so well.
So, Marian, that's one example, and I think it's a profound one. That you can, others can read your facial expressions, and there's this sense of non-technical working as well as technical working, where the team are really coming together, and there's non-verbal communication. Could I get you to speak to another example of where you've really utilized MDTs, either physically, like within that surgical capacity, or indeed remotely, where you've sort of consulted remotely and sort of get the shared decision making for patient outcome?
Yeah, I might go a step further and give you an example of a time when I didn't have the team members that I really needed. We had a patient who had quite a complicated psychosocial situation, who would often leave the hospital to access drugs and that sort of thing. And so I really needed the social worker to be involved. I also needed a physiotherapist to be hands-on because we were having trouble with mobility. And I also needed a podiatrist at the time. This was a patient with diabetes who had a chronic ulcer that we were having trouble getting on top of. Unfortunately, in that couple of weeks, I didn't have the podiatrist and I didn't have the physiotherapist. Even with me and the nurses doing our utmost to try and sort of get this patient to progress and to move forward, we actually weren't progressing at all, and it ended up in a longer admission. For some reason, the Aboriginal liaison officer was also quite busy that week, and we didn't have them on site. And even that in itself, I think, really affected the rapport that we had with the patient. And it ended up being, a 2-week admission, which probably would have been solved in 3 or 4 days if we had the whole team there. So I totally rely on our team members, and I think it's imperative that we don't just look after certain members of the team, but we look at each part of the body of medicine that we really need. And that's how I describe it. If I was missing 2 limbs, I'm not going to be able to function as well. And it's the same with a team. You can't work without the individuals who are in the team who really make up who we are as a profession.
Absolutely, absolutely, and I entirely agree with that, actually, Marian. And to your point, it really is about that cohesive team working to bring about optimal patient outcome. Could I get you to speak to just highlights, really? I guess it is a bit of a roller coaster, I guess, because you are so close to the patients, and you see them in a really powerful way over the longevity of time in rural journalism. Could I get you to speak to maybe one of the most rewarding experiences you've had as a rural journalist?
Yeah, I haven't been around long enough to deliver babies of babies yet, but I've been around long enough to be delivering multiple babies of one mother. But I think the really nice experience that I had, this is going back maybe a couple of years now, but I had a young child who was brought in by ambulance who had a playground accident. They had a quite badly fractured, dislocated elbow. And the thing that made it really scary was it wasn't just a fracture dislocation, but it was a compromise of the blood flow to the hand. We couldn't feel a radial pulse, and so obviously a really time-critical issue. The nice thing at the end of that, we managed to restore blood flow and to relocate the elbow to the right spot. But the really lovely thing was at the end of this, when we were all debriefing and I'd spoken to the mum who was there as well, the mum actually said to me, Marian, I knew that we were going to be okay when I saw you here, because you've actually helped my child just a few months before that with a different injury. And she was like, I knew when I saw you that we were going to be okay. And that was just so fulfilling to be able to go home and say, I made a difference to that family. It wasn't just a single isolated incident. I'd seen them in primary care and I knew the family, and that was lovely.
And one of the powerful things you mentioned there, Marian, is this, like you said, this building of rapport, and over time. And like you said, it's not just rapport, it's trust, and I think that's powerful because that trust is it's hard to earn that, but and it's shattered in a moment, but built up over a longer time frame. But it's powerful because actually, like you said, it's almost they know you, that whatever you bring to you, you can at least either fix or refer or deal with, which is powerful, and it's that semblance of trust which I think is excellent. Marian, could I pivot slightly and look at, so if anyone was thinking about getting into rural medicine, could I get you to speak to a piece of advice that you would give them if they were thinking about it?
Yeah, I think first and foremost, it's a great profession. Whatever anyone tells you, it's usually the people who haven't experienced rural generalism who tend to give out advice, which yeah, I think it's important to challenge that and ask them what rural experience they've had before they sort of spread any misconceptions. But the biggest piece of advice I would say is immerse yourself in every opportunity that you get. You've got this this license almost as a medical student or as a young doctor to not know everything, and no one expects you to know everything. But if you have a willing supervisor or someone who wants to give you an opportunity to learn something, use that opportunity and dive in, because you will regret saying no, and you have no idea how much that skill might end up helping someone later on. The other thing is probably a bit more personal, but decide sort of in the beginning stages whether the advanced skill that you want is more important than the geographical area that you want to settle in. There's certain pockets around Australia where, they might have a surplus of people who can do anaesthetics, or a surplus of people who can do palliative care, but they really need someone who can do obstetrics, for example. So decide whether it's the advanced skill that you really want to get good at, and you're really hooked on being good at this certain skill, or whether there's a geographical area that you'd like to settle in and you're a bit more flexible in what you learn. So yeah, they're probably the three pieces of advice that I've got.
Oh, listen, that's fantastic. And like you said, just super important questions to ask oneself, actually. Could I get you to speak to the future as you see it of rural and remote journalism? Just, I guess, for doctors that are thinking about pursuing this path and this line of inquiry, could I get you to speak to what you see or perceive to be the future?
Yeah, it's a big question. I think rural generalism, for as long as Australia has the massive, vast geographical distances that it has, with people living in every corner of such a big continent, there will always be a need for rural generalists. Um, there was a celebrity from China who visited rural Tasmania at some point, and she had this picture where she'd pose with like this little purple teddy bear, and it became really iconic as the place where people go. It's a rural area where people go to get better health outcomes and actually achieve an improvement in their health. And I think that really drives me. Eventually, I want to be part of the revolution where rural medicine is actually the place that you go to achieve better outcomes. I'm not satisfied with as good as metropolitan. I actually want us to be better, and we totally have everything that we need to be able to achieve that. You can see with our pregnant mums, we have higher breastfeeding rates, and we support women to have a birthing experience that's really positive, and it's because of that relationship that we develop with them. So that's probably what I see the future of rural journalism doing. We're oversubscribed with both colleges on the rural pathway now, and I'm part of that tidal wave of the rural revolution, is what I call it. And that's where I see us going in the future.
So just as a joiner, and I guess just finishing off on the interview as we come into land, could I get you to speak to the referral pathways in remote and rural Australia? And I guess in a way, my perception would be that they're quite robust because you have to use them so frequently, especially for non-emergency, so for the lower acuity to work. Could I get you to speak to sort of your perception and indeed your interpretation of the referral pathways? Are they quite quick? Is there quite a lot of help on the other side? Are people willing and eager to engage? How does it look?
I think the longer that I've been practicing as a rural clinician, the more complexity I'm starting to see. I don't think that there's quite a good understanding of rural generalism yet. There's still a lot of people who grow up and train in the city and don't quite know how isolated and how geographically expansive our environment is and what resources we have available. But yeah, I think Australia really needs to start to onboard all of the clinicians that are available to be able to help. We need to be able to incorporate our paramedics, for example, who can absolutely help with a lot of the presentations that we get. We need to make sure that we're making the most of, our remote area nurses who are worth their weight in gold, our Aboriginal health workers, our all of the allied healthcare team that are so strong in rural areas, and we really need to recognise them and appreciate them and value them for what they can do. I'm in a town where, the closest referral centre is 827 kilometres away. The catchment area of the health service that I work in is the size of Victoria, which is a state in Australia, probably bigger than most countries in Europe. And those expansive geographic land sizes really need to be things that we adapt to, and we sort of incorporate more people to be able to connect our networks and our patients a bit better to the services that they need. So no, I don't think we're quite there. There's a lot of work to be done, but I'm hopeful that the next generation, the millennials and the Gen Zs that I'm part of, I think will be really open to artificial intelligence and the technology that's available to be able to connect us better.
And I guess as an adjoining question to that question, Marian, do you see, because you are so close to the community, I guess in a way you can, especially with multiple attendances from various patients, is there quite a good level of compliance to both your advice and indeed to medication? Do people really, because you have that report and the trust, do you see quite a close compliance to your advice and indeed to the prescription medication that you're giving?
Yeah, I think those who take the first step, and the first step is always the hardest, those who take the first step and see a doctor, I think that in itself can be really, really valuable for us. And that's why the medicine that I do is quite different to the medicine that people do in the city, because in the city they might, have a patient that will come back for their 2-week follow-up. Whereas in my case, they probably won't. And there is so much hanging on that first interaction that I have with them to be able to say, you can trust me. I'm not someone who's trying to make money out of this. I'm not trying to sort of have any other motivation to be helping, but this is a medication that you need. This is why I think you need it. This is what might happen if we don't use it. And really taking it, making the most of that first interaction is so much more, I guess, vital in a rural area. And once people take that first step and they see us the first time, I do think that people start to engage a little bit more. But I know that that's difficult. There's been, generational trauma that we're up against in a lot of our rural communities, and that's something that we will continue to work on.
So my final question would be, just as I'm talking to you, actually, it's really fascinating, and your answers are absolutely fascinating, Marian. So it's really good to dig into this. I guess my final question would be, how much of your time, energy, and indeed consultation is spent within either palliative care or end-of-life care? Is that a facet of your work? And indeed, if it is, does it occupy quite a lot of time?
It does, and I take that as a real privilege. I think, the time of people, approaching that end of life and going through the dying process is so connecting, and so powerfully bonding. It's a real privilege to be part of it. And I don't mind what time it takes to be able to sort of walk a family through that. We've got patients who might not have seen a clinician much, but they've got metastatic cancer that's incurable. And so if I see them in primary care, or if I see them in an emergency department, there is so much importance on that communication and that rapport in that instance. And it's something that I'm grateful to be part of. It's, you know, we say rural generalism is womb to tomb. And I, you know, as much as I spend lots of time with women who are pregnant, sometimes before their pregnancy, before their conception, and I've walked that journey with them into the transition to motherhood and breastfeeding and everything else that goes with that. I think the transition into actually my body's failing, we're actually getting towards the end, and that can be really scary. But to make sure that the whole family is on board as well and understands what's happening, and for people to feel like, you know, I just need to be comfortable. We're not doing anything heroic now. We're just keeping you comfortable, and we're making sure that we get every family member that you want around, every memory that you want towards that end of life, so that you can have a nice death, which I totally believe is a real thing.
Listen, Marian, it's an absolute privilege to talk to you, and it's also fantastic just to cover such ground, because it is such a disparate and varied role, from, like you say, from cradle to grave, really. And it's powerful just to get your recollections. So thank you.
No, thanks so much for this. It's yeah, it's lovely to be able to talk about something I'm so passionate about. So I'm really grateful.
Thanks for listening to the episode. Please feel free to rate, review, and subscribe on whichever platform you're listening to. Please also head over to the World Extreme Medicine website, where you can find more engaging content on extreme medicine webinars, and indeed a collection of courses from our global network, including humanitarian, disaster relief, expedition, space, military, tactical, and performance medicine. Thanks again.